Thanks, Christine. We'll get rolling into our second half of the day. As Christine said, I get the privilege of introducing the man who literally needs no introduction, and if I attempt to describe his impact on the world, I would likely be here the rest of the day. He's emeritus professor at the University of Michigan. He is largely the reason that we are all gathered here because he had a vision, he had an idea, he got a lot of people around him to figure out how to move this forward. And so Dr. Bartlett is going to share with us kind of the basics of if you can't figure this out, you're probably not going to be able to figure out how to run ECMO. So physiology, how this whole thing kind of comes together and works. So he's going to kind of get into the basics of ECMO to start us off in this session. So with that, I'll turn it over to Dr. Bartlett.
Thanks, Liz, and thanks to all of you for being here. This is the pre-conference session, so most of you are thinking about getting into ECMO, although I learned there are people here who've already done 100 cases. You're just getting refreshed on the basics, so we're so glad you're here. What I'm going to tell you about from my point of view is the most important thing you're going to hear at this whole meeting, and I say this every year, and most important for your personal satisfaction, because you'll get so much more out of just managing sick patients, let alone ECMO people, if you understand oxygen kinetics. You all learned this as a freshman in med school or in nursing school. Most of you have forgotten it, so we're going to go over very simple basics again. So, let me see if it goes, yeah. So, what this is all about is about oxygen content. How many of you have a good idea of what oxygen content is? Just feel free to raise your hand. Okay, well, pretty good, maybe 10%, but it should be 100%. This is what you need to understand to deal with sick people, not to mention ECMO patients. So what we're going to talk about is oxygen kinetics. Oxygen is used up in metabolism. It burns carbohydrate, fat, alcohol, protein, if you're lucky, and then where does that oxygen come from? How does it get to the tissues? And how much is consumed and how much is delivered. To understand that, you really have to understand how oxygen exists in blood. And that's where this word content comes in. You know about the PO2, you know about saturation. They're not very important. What's really important is the oxygen content. The normal oxygen content in babies, adults, and everybody else is 20 cc's of oxygen per deciliter of blood. It's pretty simple. You know about pH, PCO2, O2 sat. The abbreviation for oxygen content in arterial blood is big C, small a, O2, but that looks like cardiac output, who knows what, and for venous blood it's CVO2. So we rarely use the abbreviations, although the physiologist would say that's what we ought to do, only because it gets confused with CO2, cardiac output, and so on. So we're talking about oxygen content. That's this one fact that I want to be sure that you really understand. Now, the normal oxygen consumption is the metabolic rate. It proceeds at a certain rate. We'll talk about that. And the amount of oxygen is delivered to run that metabolic machinery under normal circumstances is 5 times the amount consumed. So that ratio of delivery to consumption is very important. How far can you deviate from that before things fall apart? Can you do it too much on the high side? What you need to know is that the VO2 is what it is. The metabolic rate is set by a variety of things, and the oxygen delivery adjusts all the time to be 5 times that consumption. So the consumption goes up because you get up and walk around, you run around, you have a seizure, your oxygen consumption goes way up, delivery goes way up. It stops when it's 5 times, goes back down again. So that's what I hope you'll understand. If there's not enough delivery to meet the metabolic needs for oxygen, then there's no oxygen to run the metabolic machinery. So the metabolism switches to anaerobic metabolism, lactate is produced, and patient gets progressively acidotic. And that happens when the delivery is 2 times consumption or less. So this is the diagram of oxygen kinetics. Oh, by the way, if I go too fast, you want to go back and review this. Just review the physiology chapter in any red book. Edition 1, 2, 3, 4, 5, and 6 have all these diagrams that I'm showing to you, so that's where you can find it, including the brand new red book. Thanks, Christine, for mentioning it. So let's see if this pointer will work. If I point here, can you see it? No, you have to see it here. All right. So basic metabolism, the basal metabolic rate, or the resting energy expenditure, proceeds at a certain rate, controlled by your hypothalamus, by your thyroid hormone, that sort of stuff. And it goes up during sepsis, it goes during work and exercise. But we measure this metabolism as oxygen consumption. And the oxygen that's available comes from the oxygen in blood, that's the content, times the flow, that's the cardiac output, tells you how much oxygen is delivered to the peripheral tissues per minute. It's also true that under normal metabolism, CO2 is produced, and so it's in the venous blood, and CO2 comes out with ventilation. CO2 is the simplest problem of all, so we'll barely talk about it. It's all about oxygen. So to put numbers on all of this, for adult patients, a little different for children, for adult patients, the metabolic rate is roughly 120 cc's per square meter per minute, which translates to 3 cc's per kilogram per minute. That's the basic metabolic rate for adults. And the oxygen delivery is the content. I just told you the normal value is 20 cc's per deciliter times the cardiac output per square meter, 3.2 liters. Multiply them together and you get oxygen delivery 600 cc's per square meter per minute or per kilogram per minute, any way you want to do it. But notice that this is 5 times that. Now here's the most important one. If you if you've learned it, you learned it, but if you forgot it. This has to do with the amount of oxygen in blood, and you can measure it in arterial blood, you can measure it in venous blood, by PO2, by saturation, but what you really need to know is what the oxygen content is. So what should be obvious is if the patient's anemic, even though the PO2 is 100 in arterial blood, there's going to be less and less oxygen physically in the blood, and when it comes to something like ECMO or just sick people in general, what we really worry about is what's the oxygen delivery, and to calculate that, you have to know what the oxygen content is. And just a few examples. So here's in various levels of hemoglobin. I shouldn't have to remind you that 15 is normal. How many of you work in pediatric or neonatal units? Oh, good. You understand this. You can tune out. But the adult people have forgotten this, so they need to learn about it all over again. So arterial blood that's 100% has a PO2 of 100, has 20 cc's per deciliter if the hemoglobin is normal. But if the patient is progressively anemic, the amount of oxygen in the blood is proportionately less. Not surprising. And if you carry that a little farther, here's arterial blood and venous blood at different levels of anemia. This is normal. So the venous blood has about 16 cc's per deciliter. The difference between oxygen supply and what's left in the venous blood is 4 cc's per deciliter. This is the AVO2 difference. This is not ECMO. This is just physiology. You should know this. What's the AVO2 difference? And if the patient's anemic or really anemic, then there's just, even though the PO2 is still 140, the amount of oxygen that's actually transferred in the process of breathing, in this case, is, of course, much less, not surprising. So you can see that content and hemoglobin are intimately related, but if you just know the hemoglobin, then this is for adults, but if the hemoglobin times the cardiac index per square meter per minute. So the normal value is here, 3 liters per square meter per minute, hemoglobin of 15 with oxygen content of 20 gives you 600 cc's a minute, which is normal baseline systemic oxygen delivery. Remember, the consumption is only 120, so it's 5 times as much. Now, to take that a little farther, here's what we're just talking about: normal oxygen consumption, in this case 3 cc per kilogram per minute. These are adults. Children are about twice that. And the normal delivery is 5 times that, or 15 cc's per kilogram per minute. That's the normal point. So normal physiology is right there, and it's 5-to-1 ratio, and the venous saturation will be 80%. That's just works out to be convenient.
I'm going to give you this so everybody can hear you all the time.
Oh, I'm sorry. I'm turning away from the microphone.
It's okay.
Christine, remind.
And put that on your pocket, and then
All
you're
right.
good to go.
Good. Sorry. If you couldn't hear me, brief review. If you don't have enough hemoglobin, you won't have much oxygen in your blood, and that's true across the board. And so if you know what the hemoglobin is and assume that it's 100% saturated, you can calculate what the oxygen delivery is without having to do the arithmetic. So here's the normal point, 3-to-1 ratio. Can you still hear now? Is that working? Good. And it just turns out, it's an accident of arithmetic, that full saturation is called 100%. So if 20% of the oxygen is gone, the venous sat's going to be 80%. So that's fortunate, because all we need to know is what the venous saturation is, and we know what the ratio is between delivery and consumption, regardless of anything else that's going on. So it's really convenient. So here's the normal point. And if delivery gets decreased, cardiac output goes down, patient gets hypoxemic, patient gets anemic, then they move down this chain here, and it's going to be reflected as less oxygen per unit of consumption. So the venous sat's going to go down as more oxygen is taken out. Nothing wrong with that. People here are totally stable until you get down here where the ratio is 2-to-1. Now there's not enough oxygen to run the machinery. So that if you keep that in mind, and we're just talking about sick patients now, not ECMO patients, the normal ratio is 5-to-1, venous sat's 80%. If you get down to the point where arterial blood is 100% saturated, but the venous blood is 50%, now you're going to be in trouble. That's going to get you into lactic acidosis and so on. You could even quantitate that by measuring how high the lactate is. So look at we talked about delivery going up and down. If consumption goes up and down, then normally the delivery compensates. So if you go from a resting state to just walking around, you double your oxygen consumption, and the delivery will double and go back to a 5-to-1 ratio. So if you think about all that, it fits into this thing. If you just had a monitor at your bedside, we actually built one, it works beautifully. So as long as you're in this range, that couldn't be more normal. If you're in this range, you're using up your reserves. If you're in this range, that's going to be shock. So imagine a cursor just saying, here's where you are in this phenomenon. So now to ECMO. As you all know, people who have cardiac failure or respiratory failure, it's all a problem of oxygen delivery in relationship to oxygen consumption. So if you understand all that, you'll do a better job of taking care of a sick patient in your ICU. But what you do is give them more oxygen, you increase the ventilator pressure, you give them vasopressors, inotropes, you might paralyze them to cool them down, and that's the state-of-the-art treatment. Often it works, oftentimes it doesn't work, but with ECMO, we have totally different algorithm for managing the patient, And what we basically do is take all these things and take that over. We can just dial it in with our ECMO machine, all the things on that variable. You can make the hemoglobin and the blood flow and the delivery and even the ventilation, anything you want it to be. What a remarkable treat. So now you need to know about a membrane oxygenator and how it works. And it's the same idea of AVO2 difference, how much oxygen is going in venous blood, how much oxygen is coming out fully saturated blood, assuming your oxygenator is below rated flow. And these are just examples for different levels of hemoglobin and anemia, so that you can do all the arithmetic and calculate the AVO2 difference in your membrane lung and calculate how much oxygen you're giving at different levels of ECMO flow. It's the same physiology. So the bottom line of that is you're running ECMO on a patient and you're trying to deliver, let's say for an adult, 240 cc's a minute of oxygen. That's baseline for 80 kilogram adult. So if your hemoglobin is 12, you're gonna need about 4 liters a minute to do that. But if your hemoglobin is 8 or 9, why? You're gonna need 5 or 6 liters a minute to give oxygen to that patient. If the patient is nice and normal, the hemoglobin of 15, you only need 3 liters a minute to supply the patient. Oh, so that's all about oxygen. I hope you understand it. I hope you'll remember it. You'll feel much more better about yourself if you're at the bedside. So here's what I'm doing. Oh, by the way, I'm giving 8 units of red cells, and it's okay. This idea of being anemic if you're really sick doesn't make any sense at all, especially in an ECMO patient. Oh, CO2 doesn't need much. The higher the sweep gas, the more CO2 you're going to blow out. CO2 is really easy, so it's not but you have to remember the sweep gas composition, oxygen, nitrogen, stuff, and the rate of flow are totally different. Composition is related to oxygen. The flow rate is related to CO2 clearance. All right, so I hope you remember that and understand it. Thanks very much.
All right, next I'll invite back up Dr. Egerstrand, who's at New York Presbyterian Hospital. So Kara's going to talk to us on VV concepts, and so she'll kind of whittle down the essential management tips for you all.
Thanks, Liz. Well, I didn't realize I had to follow Dr. Bartlett with this talk, so now I'm sort of regretful. But yeah, so for the next 15 minutes or so, we'll discuss sort of some of the very essential kind of big picture VV ECMO management principles. And, of course, this is why we have a multi-day conference. You can't squeeze all these in into just 15 minutes, but we'll try to hit on some of the high points and hopefully give you some evidence and management strategies regarding those. So this is our overview for the next 15 minutes or so. We'll kind of focus on gas exchange, the idea of lung rest, patient's volume status, and sort of a general approach to pharmacology. So the first question we need to ask ourselves, really, and sometimes it's a little more complicated than it seems, but is VV ECMO the right configuration? All right, well, how do we know that? Well, what is that patient's primary problem? Sometimes, a lot of our patients have a lot of different problems, but what is that patient's primary problem? And if the primary problem is respiratory, VV ECMO is typically the right configuration. So we're thinking hypoxemic respiratory failure in ARDS, hypercapnic respiratory failure for the same, as we know from the EOLIA trial, there's a mortality benefit even in patients with hypercapnic acidosis, or severe hypercapnia in the setting of status asthmaticus. People rarely, but sometimes have very severe bronchopleural fistulas, in which case VV ECMO can be initiated, the ventilator pressure can be reduced, allowing that BPF to heal, that air leak to be reduced, or as a bridge to lung transplantation. On the contrary, patients who require veno-arterial ECMO really have a primary cardiac problem. And I list VA ECMO up here, even though we're focusing on VV, because sometimes it gets a little bit muddled. This includes patients with massive PE, patients with pulmonary hypertension, either acutely decompensated or maybe either as a bridge to recovery or possibly bridge to transplant. Those with acute or chronic heart failure, including things like stress or septic-related cardiomyopathy, sometimes with associated concomitant ARDS. as a bridge to transplant. That can be heart transplant, certainly, and also lung transplant, a patient who has concomitant PH. Often we see this in our ILD patients, especially as the disease progresses. And finally, ECPR, which is, we've seen some pictures of, and I love this photo more than any of them all, is that, an unfortunate tourist getting cannulated ECPR in the Louvre as, he was walking around viewing some of the graves. This is unfortunately an American tourist. Was supported on VA ECMO in that sort of acute situation. But it's important to really note here that, and sometimes people think about VA ECMO as simply an upgrade to VV ECMO, and that's just really important to dispel that myth, because that's not really the problem. What we want to think about is what that patient needs. And as you can see here, when you look at the effects of configuration on the O2 delivery, as Dr. Bartlett so wonderfully described, the DO2 to the carotids, to the coronary arteries, to some of these vital organs we want to perfuse, the DO2 with VV ECMO is certainly going to be higher than with VA ECMO, even in patients who have one of these hybrid configurations, a VAV, for example, due to the required splitting of that total blood flow that is needed in those configurations. So VA ECMO is not simply an upgrade, but while that does offer hemodynamic support, we may actually be hurting ourselves as far as that oxygen delivery that we want to maintain. Okay, the next thing to really think about is what is our configuration going to be, our cannulation approach going to be? Is that going to be dual site or single site cannulation? And sometimes that may be dictated by the person doing the cannulation, whether it's in the cath lab or in the OR or whatnot, but that's certainly a discussion that, as whether you're a medical person or a surgeon or whomever, we should all be a discussion to think about what are the pros and cons of each. And it might be a dynamic situation. So it's probably the most commonly used configuration for VV is going to be a dual site configuration. That's typically a femoral drainage, okay, through the ECMO circuit to an internal jugular vein return. However, not always. You can also do this successfully, as I know Dr. Mason does here in the front, a femoral approach where there's some femoral drainage and femoral venous return as well, mindful of any degree of recirculation. Some advantages of a dual site VV is that this can be done at the bedside, right? When that patient is so unstable and their O2 status 65% and they're on high-dose pressors, this can be placed at the bedside with ultrasound guidance using Seldinger technique, as we're all familiar with, okay? Now, one of the disadvantages of dual site VV is that we do need to monitor for this unique VV complication or occurrence of recirculation. Recirculation being that degree of ineffective or inefficient blood flow that can occur in a dual site setup. So as we know, the goal here is going to be to have that blood pulled out into the ECMO circuit, reinfused in that well-oxygenated, low CO2 content blood, and then that blood is going to be in the venous system, cross the tricuspid valve, go through the lungs, which aren't really working, and then pump through the left side of the heart and out to the body. However, especially maybe with cannula positioning issues or in the setting of changing positions or changing diuresis, sometimes that reinfused blood flow, that good newly oxygenated blood gets sucked back out into the circuit itself, right? Creating this blind loop or this inefficient or ineffective blood flow known as recirculation. Definitely one of the things we want to monitor for in this configuration. Now, another approach is going to be the single site or dual lumen cannulation approach. Typically, this is with a dual lumen cannula placed in the right internal jugular vein. However, the left side has been used as a subclavian vein, where blood is withdrawn from two ports, one positioned in the SVC and one positioned in the IVC. Blood flows from the venous system, from those two ports, into the circuit, and then reinfuses through the different lumen of that same cannula with that blood reinfusion directed across the tricuspid valve. So here you can see the advantage would be that we're minimizing that recirculation, right? We're really directing that reinfused blood where we want it to go, which is the cross tricuspid valve, so it can follow the normal circulatory route, and really maximize the efficiency of our blood flow. However, unlike dual site configuration, this requires a little more technical placement, right? Oftentimes we want to use fluoro to make sure that the height or depth of the cannula is appropriate. We want those ports to be in the SVC and the IVC, not malpositioned. And we want to use echo as well. We want to be able to see that reinfusion jet so we know that that reinfused blood flow is directed where it needs to be. We don't want that reinfusion flow to be hitting the wall of the atrium or anywhere else and decreasing the amount of blood flow that we can achieve. Okay. Now, patient goes on ECMO. What about our initial and ongoing circuit adjustments? So sort of where do we start? Like, how do we start this? So I think it's important, and Dr. Bartlett touched on some of this, in really thinking about what we care about, right? We care about oxygenation and we care about ventilation. And in some ways, it's easy to think about them separately. So with oxygenation, we want to adjust the blood flow on the ECMO circuit to achieve adequate DO2, mindful of our circuit pressures, okay? And I say adequate DO2 and not O2 sat, as part of my talk was to be explaining why this is so important, but Dr. Bartlett so eloquently hit on the idea of like DO2. I think we can go through that pretty quickly, but we do want to make sure that the oxygen delivery is adequate for that patient. All right? We don't need to adjust the ECMO circuit or adjust the blood flow to achieve physiologic perfection. What we're looking for is physiologic adequacy, because you can turn the dial all day long. Blood flow up, blood flow down, what's the PO2, what's the SAT. But if that patient's lactate is normal, if they're making urine, if other parameters of systemic oxygenation are okay, you can kind of assume that we think that DO2 is adequate for that person, and that may be a dynamic state. Okay? With ventilation, as opposed to adjusting the blood flow, we're going to be adjusting the sweep gas flow, right? Because we know that even at low rates of blood flow, because CO2 is so soluble and diffuses quite readily across that membrane, we can achieve adequate CO2 clearance with adequate sweep gas flow. So we want to adjust the sweep gas flow to achieve adequate CO2, mindful of the rate of correction, okay? And I say here adequate CO2, and again, not physiologic perfection, not necessarily normal CO2. If that patient had a chronic hypercapnic acidosis, let's say they are a cystic fibrosis patient awaiting transplant, and their baseline CO2 is 60, you don't want to turn that sweep gas onto 4 or 5 liters and get that down to 40, right? They're going to become alkalotic. They could have problems, especially with a fast rate of correction, including things like cerebral vasospasm, hemorrhage, seizures, and the like, okay? And I also intentionally do not say here that we want to achieve a normal pH, right? Because we are not going to be adjusting that CO2 to offset a severe metabolic acidosis. You may put that patient on ECMO and with a lactate of 12 or 14, and you're not going to be getting a pH of 7.4. What you might be getting is a pH of 7.25 or 7.27, and that is going to be adequate as you allow things to sort of slowly correct, okay? In addition to sort of these principles, we also want to really be mindful of the fact that this is a dynamic process. It's a very dynamic state depending on that patient themselves. So with oxygenation, in addition to the blood flow, what's going to affect the degree of support we're giving to that patient? Well, the cardiac output, metabolic rate, the patient's native lung function, which can change quite substantially during the run, and also this degree of recirculation. For ventilation, we want to be mindful of that CO2 gradient itself. Higher gradients across the membrane are going to allow for more rapid CO2 clearance, the absolute value of CO2 as well, and some of the degrees of membrane efficiency. Okay. Fantastic. So is that it? Are we done? No. So now the vent. And I think, if we can emphasize one thing, it's that ECMO alone is not enough, right? You can put all the cannulas you want into somebody and normalize their oxygenation, normalize their ventilation, but if you don't use that tool to allow you to reduce the harm the ventilator can do, you're not using ECMO to its full benefit, okay? So what we want to work toward is achieving an idea of lung rest ventilation, shifting the work of breathing from the patient, or the work of respiration, of gas exchange, from the patient to the circuit, okay? So what does that mean? It means memorize this. I'm just kidding. But it's the idea of really reducing the mechanical power to the lungs, right? Reducing the rate, the respiratory rate, and reducing the energy or the pressure that's applied, okay? And we know that ECMO is effective in doing this, and looking at the Eolia trial, once that patient is on ECMO, and where those red arrows indicate, you can see that minute ventilation is able to be reduced, respiratory rate drops, tidal volume goes down. And what we know is that as we match CO2 removal via the circuit to CO2 production, okay, you can see along the x-axis here, as CO2 removal via the circuit nears 100% of CO2 production, what happens to alveolar ventilation, right? Well, it drops, right? That nearly linear away to 100%. So a respiratory rate reduces, tidal volume decreases in a naturally breathing patient, And at that point, you can have alveolar ventilation nearly cease. So you can have a patient like this young man with severe ARDS, max vent settings, a day prior, inverse ratio I to E, sedated, paralyzed, and the like, supported with sweep gas removal of CO2, breathing 5 or 6 times a minute very comfortably. Okay. This is further indicated in this more recent study by Crody and colleagues, where you can see at high versus low levels of sweep gas, okay, the blood gases in these patients are basically the same. They don't change, but what you're doing is shifting that work from the patient to the circuit. So again, respiratory rate drops as you increase the sweep, and the esophageal pressure swings or some of that changes in pressure that may exacerbate lung injury also decrease. And you can see here the pH, 746, 749, CO2 in the 30s, don't really change at high or low levels of support, but what we're doing is where that work is delivered to, okay? Have the circuit do the work, not the patient. In thinking about the pressure side of things, and the idea of like, what is an optimal plateau pressure or total pressure in someone on ECMO? We don't know the right answer to that, but we know that the evidence that we showed in the EOLIA trial, for example, they used a respiratory rate less than or equal to 24, right? So potentially we can enhance upon standard of care, ARDSNet, low tidal volume pressure ventilation, right? Less than 30, kind of standard in our non-ECMO patients. In ECMO patients, we can probably do better on that. And looking at some retrospective data from the original ARDSNet publication, lower day one plateau pressure was associated with lower mortality in this group of patients. That was true even when stratified by quartile of plateau, where some of that plateau level was likely determined by the randomization group in which the patient was placed, either the 6 cc versus 12 cc per kilogram categories. So, there's a lot of evidence suggesting that that may be helpful. In one of my favorite studies from 2009, actually, a group of 32 patients was maintained on ARDSNet protocol with low tidal volume approach to mechanical ventilation for 3 days, okay? In the 22 patients of this group who had plateau pressures of 25 to 27, so we'd be pretty happy, right? They're on the vent, 25 to 27, they were maintained on the vent as they were. However, in the 10 patients in this group who had a plateau pressure of 28 to 30, so still what we'd consider within standard of care, right? Less than 30, et cetera. They had their tidal volume decreased to achieve an even lower plateau pressure, less than 28. If in doing that, their pH dropped below 7.25, ECMO or ECOR, low flow ECMO, was initiated, okay? And what we saw was that 3 days later, in the control group where the levels of inflammatory cytokines and those associated with lung injury did not change, in this group that was placed on ECOR or low-dose ECMO, low-flow ECMO, these inflammatory cytokines decreased further after further reducing the ventilator. So it may be that we can enhance upon what is already considered to be standard of care when our ECMO technology allows us to do so. Okay. As we teach, and there's no one right way to achieve lung rest ventilation, but kind of one thing I like to tell people is that if you think about it simply, you can think about pressure control setting of 10, 10, 10, and 40. Easy to remember, but certainly these things will need to be adjusted per patient, but with the idea being low rate, low pressure, and really maintaining a moderate level of PEEP to prevent total atelectasis. All right, what about volume management, okay? Well, I like to say that a dry lung is a happy lung, and that's the pulmonologist in me. But we do know that ARDS patients need aggressive diuresis. We don't be deceived by their often euvolemic appearance, or if someone tells you they're euvolemic from outside hospital, you never believe them. But we know that we do need to often substantially remove fluid in these patients. They've got a lot of extravascular lung water. Even if they're on low-dose vasopressors, provided they're not in the profound septic shock or something that requires fluid administration, we really want to be very cautious about the fluid we're giving people and try to take it off as soon as we can. Okay. We know that building off the FACT trial, right, one of the original ARDSNet trials, we're randomizing patients to various fluid strategies, conservative versus liberal fluid. In this group of patients, who were randomized to that conservative fluid management approach, okay, what they saw was increased ventilator-free days, improved oxygenation, decreased ICU days, and a trend toward decreased mortality. However, these are patients who are much less sick than the ones we're taking care of, right? These patients had an average PDF of 150. And so whether the degree and aggressiveness of our ability to remove excess fluid and really be cautious of fluid intake, what benefit that might have in our ARDS patients in particular, is something that kind of warrants, really like thoughtful consideration. How do we handle chatter in these patients? This always comes up is like, well, what do you do when that pump is chattering, when the cannulas are cutting out? We try to abstain from giving extra fluid as much as possible, right? We want to maybe not administer fluid on the first go. We want to just try to maybe decrease the RPM slightly, decrease the blood flow, let some of that extra vascular water and edema sort of re-equilibrate into the intravascular space before turning that pump back up. Or maybe that patient can get away with a slightly lower RPM in blood flow. Maybe the DO2 is adequate at 4 liters versus 4.5 liters, allowing us to be more aggressive with volume removal. Okay? And certainly evaluating for kinking in the cannula tubing or changes in extrathoracic or intra-abdominal pressure in the setting of pneumothorax, for example, or abdominal compartment syndrome, or other things that may provincially contribute to that development. And finally, just to touch on briefly, pharmacology, right? There's a lot we don't know about drugs and their interaction with the ECMO circuit, but one thing we do know is that they do interact. This is particularly true for lipophilic medications. The ones that come to mind, probably to all of your minds, are sedatives, opiates, all these things we need to use to keep patients comfortable and minimize ventilator injury, maximize vent synchrony and whatnot, okay? But just be very mindful of the fact that a lot of drugs need dose adjustments. Sedatives being one of the most common, also antibiotics, antiepileptics. If you are using antifungals, for example, maybe you want to choose one like voriconazole, where you can measure a level to know if that level is actually therapeutic in that patient on ECMO, okay? Or choose other drugs where you can measure and follow levels to understand better what we're actually delivering to that patient. And one thing I always like to mention is just, and always remember that especially with our lipophilic medicines, like our sedatives, for example, that patient might come to you sedated, on their Versed or their fentanyl drips, RAS -5, you place them on ECMO, some of those lipophilic medications get absorbed into the circuit, that patient might still be paralyzed, and now they're actually awake under the paralytic. So it's very important to remember after cannulation to stop those things, stop the paralytic, reassess where that patient is, get them in a steady state post-cannulation, and then reconsider if that paralytic needs to be resumed, which it usually does not. So in summary, the essentials: target gas exchange to achieve physiologic adequacy, minimize mechanical power on the lungs with lung rest ventilation, be mindful of volume status, a diuresis is often needed and often needs to be aggressive, and be aware of the pharmacokinetic impact of ECMO. Thank you very much.
Yeah, you're welcome to. All right, next I'll bring back up Raj Ramanan, who is intensivist at UPMC, their ECMO medical director. He gets to speak about when the heart fails. So Kara just went into the VV side. Now he'll flip over and kind of talk about how to navigate those pesky heart failure VA patients. So welcome up.
Good afternoon, everybody. I'd like to thank the organizers of this inaugural pre-conference for inviting me here to speak about a subject matter that I'm very passionate about. And it's also great to have ECMO providers from all across the world come together here and discuss best practices for all their new and nascent programs. So the topic of my discussion today is when the heart fails, managing patient on VA ECMO. These are my disclosures. So I'd like to start my talk today with a case of a 19-year-old woman, college athlete, college freshman, an avid athlete who was in her usual state of health when she suddenly began to develop complaints of chest pain and shortness of breath. These symptoms progressed over the course of 2 weeks to the point where they were debilitating enough for her to not be able to attend classes, not be able to participate in sports, and she was promptly transferred to our emergency medicine department for further evaluation. Upon arrival, she was noted to be tachycardic but normotensive. Her admission EKG revealed sinus tachycardia with no acute ischemic changes and no arrhythmias. Her chest X-ray demonstrated bibasilar infiltrates, which was confirmed by her CT chest, and of note, the CT was also negative for an acute PE. Her pregnancy test was negative. Her urine drug screen was negative. But unfortunately, she started to develop progressive hypoxia, quickly failed non-invasive ventilation, and was urgently intubated and then transferred to our ICU for further management. Immediately upon her arrival to our ICU, a transesophageal echocardiogram was obtained, which revealed severe biventricular failure with a dilated left ventricle. Simultaneously, right heart catheterization was performed, which revealed elevated biventricular filling pressures, a low cardiac index, and a low PA saturation. Given the constellation of these findings, our presumptive and working diagnosis was de novo acute decompensated heart failure complicated by cardiogenic shock. She was started on a combination of both vasopressors and inotropes, doses of which continued to rise very rapidly. Her kidneys started to shut down, her liver started to shut down, and her lactate levels continued to rise. Given her rapid deterioration with just conservative medical management, the shock team was rapidly convened, and after a discussion that we had amongst ourselves, the decision was made to proceed with peripheral VA ECMO support. So she was cannulated at the bedside and then stabilized. So Prashant Rao and colleagues here have described some of the cardinal considerations when assessing a patient for ECMO support. In today's talk, I'm going to be focusing specifically on stabilization and maintenance phases as it pertains to the titration of ECMO blood flows and achieving native heart rest. But before we kind of delve into the clinical aspects of management, what I want to focus on is also going over some basic cardiovascular physiology. I think Dr. Bartlett's already stressed enough on oxygen delivery. I'm going to be discussing PV loops, which I know is the bane of many people's existence, and I will make it as brief and as painless as possible, but please bear with me. So here we see a normal PV loop, which is usually trapezoidal or quadrangular in shape. The four sides of the PV loop correspond to the four phases of the cardiac cycle: isovolumic contraction, ejection, isovolumic relaxation, and filling. The two isovolumic phases are energy-dependent processes, and the ejection and filling phases are passive or non-energy dependent. And our PV loop falls between the boundaries of the end-systolic pressure-volume relationship and the end-diastolic pressure-volume relationship. These describe the contractile and the relaxative properties of the left ventricle, respectively. And where this PV loop falls between these two boundaries are determined by the ventricular afterload and the ventricular preload. The width of the PV loop is the stroke volume, and the height is the end-systolic pressure. So here, using the Harvey simulation software, you can see what a normal PV loop looks like in a patient. I'll be making references to these simulations as we move forward as it pertains to our case that I just discussed. So the area bound by the end-systolic and the end-diastolic pressure-volume relationship corresponds to the pressure-volume area. This is the sum of the stroke work and the potential energy that's stored in the myocardium at the end of systole. And this pressure-volume area is directly correlates or is linearly correlated with the myocardial oxygen consumption per beat. So as the pressure-volume area increases, the myocardial oxygen consumption increases. This relationship shifts upwards when the LV contractility increases, for example, with the use of inotropic agents. So here we see a PV loop of a patient with acute cardiogenic shock. There's a marked decrease in the slope of their end-systolic pressure-volume relationship due to a decrease in LV contractility. We can also see there's a concomitant decrease in the stroke volume, as well as an elevation in filling pressures and volumes. This, again, is displayed here on our simulation. And with the institution or addition of vasopressors and inotropes, we can see there is an increase in the slope of the end-systolic pressure-volume relationship, as well as an overall increase in the pressure-volume area. This essentially just means since the PVA has gone up, so has the myocardial oxygen consumption. And with the initiation of peripheral VA ECMO support, we can see there's a complete change in the morphology of the PV loop, which I'll be delving into in a little bit more detail as we move through these slides. So after the first minutes to hours following ECMO initiation, it's usually a time of very rapid physiologic and metabolic changes. With the rapid correction of systemic acidosis as a result of increased tissue oxygen delivery, providers have to be very careful to electrolyte abnormalities that can occur with rapid pH changes. Also be very aware of changes in vasopressor requirements and the reperfusion of ischemic end organs. Patients with cardiogenic shock usually have multiple neurohormonal mechanisms that are activated in order to be able to increase their systemic vascular resistance to compensate for their decrease in cardiac output. This high SVR usually shifts to either being low or normal with ECMO initiation. And the high afterload may limit ECMO blood flows as soon as you go on support. But as the patient starts to vasodilate, flows will increase. And also providers have to be cognizant of the fact that sometimes volume resuscitation may be required in order to be able to achieve target flows. So the goal of the stabilization and maintenance phases, like I described before, are optimizing and titrating ECMO blood flow to what the patient needs and being able to promote and achieve native heart rest. So increasing or augmenting ECMO blood flow leads to an increase in tissue oxygen delivery. Centrifugal pumps are all preload dependent and afterload sensitive. And what this means is with the institution of ECMO, there's a rapid decrease in the right atrial pressure as a result of central venous decongestion. So sometimes these patients may require aggressive volume repletion in order to be able to maintain enough preload to the pump for efficient ECMO blood flow. Also, with the institution of peripheral VA ECMO, the afterload that the pump is going to see may be really high in the presence of high doses of vasopressors and may necessitate very rapid down titration of vasopressors or the addition of vasodilating agents in order to be able to optimize ECMO blood flow. So how much flow do we really need for these patients? There's no magic number, there's no one size fits all. It's whatever is needed to reverse the shock state and achieve adequate end organ perfusion. Various hemodynamic and biochemical markers can be used in a goal-directed therapy fashion in order to be able to optimize ECMO blood flow. Some of these are listed here, such as central venous oxygen saturation or mean arterial pressure targets, lactate clearance, or the improvement in end organ function that can be monitored using routine blood tests. Here we can see that once you put a patient on ECMO, there always has to be very careful titration between the two flows that are seen. One is the antegrade pulsatile native cardiac flow, and the other one is the non-pulsatile retrograde flow from the ECMO circuit. So providers have to be very careful with titrating ECMO blood flow enough to be able to maintain tissue organ perfusion, but at the same time ensuring that some amount of native pulsatility does remain. So the core tenet of native heart rest centers around decreasing myocardial oxygen consumption, and this can be done through minimizing vasopressor and inotropic use, as well as through left ventricular unloading. So here we can see with the weaning of pressors and inotropes, we can see there's a downwards and leftwards shift of our PV loop. This essentially means that the pressure volume area has reduced and therefore myocardial oxygen consumption. With peripheral VA ECMO, there's active loading of the left ventricle that does occur when patients go on support. You can see with increasing ECMO blood flows that there's an increase in the left ventricular volumes and pressures, there's an increase in the aortic pressures, and there's also a very rapid decrease in the right atrial pressures. And we can see on the figure on the right that with increasing ECMO blood flows, the effective arterial elastance, or the afterload, continues to increase to the point where there's a concomitant decrease in the stroke volume, as well as increased filling pressures and volumes. So here with peripheral VA ECMO, it increases the LV afterload and wall stress and tension, thereby contributing to LV distension, increased myocardial oxygen consumption, stasis within the left ventricle and the aortic root, pulmonary edema as a result of elevated left atrial pressures and pulmonary venous pressures, as well as reduced coronary perfusion as a result of increased end diastolic pressures. So the prerequisites for optimal support strategy in patients that are on ECMO include providing circulatory support, active ventricular unloading, augmenting coronary perfusion, and central venous decongestion with renal hepatic unloading. But here we can see with peripheral VA ECMO alone with the failing left ventricle that even though it offers excellent circulatory support and actively unloads or actively decongests the central venous system, it does not unload the left ventricle and it does not augment coronary perfusion. So how can we make the situation better? We can make the situation better by unloading the left ventricle, and for that there's a multitude of different venting strategies that are displayed in this figure here, both direct and indirect, both surgical and percutaneous. The width of these arrows generally reflect the efficacy of the venting strategy that's been described. So the question becomes, what is an ideal LV vent? An ideal LV vent is one that's able to offer circulatory support, that actively unloads the left ventricle, and augments coronary perfusion. So the combination of peripheral VA ECMO with the optimal venting strategy can provide all of these parameters and becomes an optimal support strategy for patients. For our specific patient that I was describing earlier, we use a surgically implanted Impella 5.5 in order to help vent her left ventricle, and this combination therapy is otherwise known as ECPella or ECMella. So here we can see with the institution of this venting strategy that our PV loop morphology changes very rapidly into one that's triangular. This is because of the continuous unloading of the left ventricle with our venting strategy, as well as because of the abolishment of the isovolumic phases of contraction and relaxation as well. So I'd like to introduce everybody here to Brooke Sturgis, who was kind enough to allow me to share her story with everybody and want to let the ECMO community know how big of an impact this therapy had on her life. She was supported on this ECPella strategy for about 2 to 3 weeks and received a heart transplant and has been doing great ever since. She's come back and visited us in the ICU multiple times, and she's gone on to become a big, she's gone on to achieve so many things in her personal and professional life, and we're very proud of what she's been able to do. So I'd just like to thank our entire ECMO program as well. I think some of our team is already here from Pittsburgh, so thank you for all the hard work that you do, and thank you everybody for allowing me to speak.
All right, last but not least for our formal presentations today, inviting up Dr. Troy Seelhammer, who is ECMO Medical Director at Mayo Clinic in Rochester, Minnesota. He gets to finish up the basics topics with talking about anticoagulation, something that you as well will have to know and love to be involved in the ECMO world. So thank you.
Thanks for the kind introduction. I have the unenviable task of being the last speaker between all of you and dinner. So I will try to be cognizant of everybody's time, and we're going to spin through some interesting concepts here today. What I'd like to do is to provide, over the next 10 to 15 minutes, a framework that underscores the foundational understanding for the pathophysiology that necessitates the administration of systemic anticoagulation in ECMO. And later on in the presentation, we'll try and touch on how to manage thrombotic and perhaps hemorrhagic complications if and when they occur on ECMO. Starting with the hemostatic activation, and I would argue that the best way to approaching ECMO management is to try and simplify this to its core, fundamental, basic concepts as best you can, master them. And once you master them, then you can unfold and unlayer the onion and tease out the nuances of care. But you have to start with the very basics. And for ECMO management, as far as hemostasis goes, starting with hemostatic activation, I'd urge you to consider contact phase activation. What contact phase activation is really the series of reaction that occurs after the binding of metabolically active proteins onto a charged surface, perhaps an artificial surface. And what happens in ECMO is you get this contact phase activation where it's the blood interacting with the foreign material of your ECMO circuit, and that leads to something known as thrombin generation or a thrombin burst. You'll understand in a few minutes why I would argue that the thrombin burst is the enemy for ECMO, and it's something that we should all consider on a daily basis. This is a slide that urges a pause to consider the design and construction of an ECMO component. In this particular example, this will be an artificial cannula. This gray line denotes the polyvinyl chloride tubing, and on that tubing, in most circumstances, is some sort of biocompatible surface coating. This is also applied to many of our artificial oxygenators, the polymethyl pentene oxygenators, and even some pumps have these biocompatible coatings. But these are imperfect. They do not reflect a normal endothelium, and they're not, in many circumstances, actually metabolically active. So what happens is you expose this biocompatible membrane on this polyvinyl chloride to circulating blood. And notice here you've got red blood cells, you've got platelets, you've also got white blood cells, and a bunch of other stuff. And very quickly, within just moments, you get a bunch of binding of fibrinogen. That's really the first step. And after fibrinogen is a whole bunch of other things. And you can see them listed on your slide. The most relevant ones perhaps are high molecular weight kininogens, albumins, complement, and immunoglobulins. And from here, you get a migration of platelets onto this pseudoendothelium, and it sticks to the surface, known as platelet adhesion and platelet activation. These platelets degranulate. They secrete a whole bunch of active compounds, paracrine stuff that activates additional platelets, that calls into activation of the immune cascade, and ultimately you get calling into S service some white blood cells. The neutrophils stick to the surface, they release additional cytokines, and you get complement activation. This leads to some small quantity, just trace amounts of local release of thrombin. Local, that is, to this small region you're seeing on the display, but if the circuit is large, it's not all that local. And eventually, most of the circulating blood volume is exposed to that foreign material. This thrombin generation is upregulated or accelerated by a tissue factor, and what you get here is this thrombin burst, this massive propagated accelerant of thrombin. And from here you get just a little bit of clot, and that's this nidus that I've tried to render here for you. And this is a little bit of platelets, it's a little bit of red blood cells, and it's a whole bunch of fibrin. Once this clot starts, it does its own thing. From here, at least locally, the cat is a little bit out of the bag here, and it becomes a bit more challenging to manage. Notice that it can very quickly occlude this local region, or it could break free and embolize. Maybe it just releases enough of these inflammatory activated compounds whereby the entire inflammatory cascade and immune cascade are preferentially upregulated, placing this patient at a disadvantage. I wanted to also spend a moment talking about platelets. Platelets are essential. We know this. You all know this. They do a bunch of things, one of which is really, really basic but underdescribed. It is present. It has a phospholipid membrane. The phospholipid membrane is an essential cofactor for the rapid enzymatic cascade that leads ultimately to fibrin generation. Actually, you can't form good clot without the presence of a lot of phospholipid membrane, and platelets help to achieve this locally. Additionally, they become tethered to damaged endothelium through von Willebrand's factor. They stick to collagen in that process. They stick to one another as well through tethers. So these pseudopods reach out and touch each other. Eventually, you get reversible aggregation. Here, this clot isn't yet firmed up. Maybe this leads to some microembolic phenomenon, some microaggregates that circulate and cause disadvantageous downstream effects, but we don't detect these clinically. If it's allowed to continue to be present, though, you get activation of the secondary hemostatic cascade, and here you get stabilization of this plug. Fibrin-insoluble monomers become insoluble, and when they become insoluble, they polymerize, and they start to shrink down and ratchet down, and actually the size of that physical platelet plug will shrink a little bit, but it will firm up, and now it has to be enzymatically degraded to allow dissolution. So to summarize, platelets, they get large, as much large as they can. They call into service their friends so that there's more phospholipid membranes present at these local sites of injury. They connect to one another, and they increase their surface area. How about what has been done over the last several decades to simplify the circuitry? Really, ECMO is a derivative or modification of a cardiopulmonary bypass circuit, but there are major differences. And one of the major differences is the removal of the hard cardiotomy reservoir. For those unfamiliar, what the reservoir does is it is a chamber. It's a depot allowed for the blood to collect and pool so that if you get disruption of your venous drainage, you can continue to provide cardiac output or flow, draining or drawing from this reservoir. But that reservoir, by definition, has stasis. It has stasis, which is a very strong trigger for regional or local concentrations of these immune-activated cascades, these hemostatic cascades, and activated platelets. And in fact, without anticoagulant, blood will gel or clot within the reservoir. ECMO removes this reservoir, at least in most conventional circuitries. This is a busy slide, and I wanted to put it up here to show you some commonalities with cardiopulmonary bypass and also some differences. Of course, both approaches need some way of draining blood from the patient. So you need a large bore venous cannula. That is how you get the venous blood into your machine. You also, of course, need some way of redelivering that arterialized, decarboxylated, oxygenated blood back into your patient. You need some sort of pump. Most circuits these days are centrifugal pumps. You need an artificial lung to perform your gas exchange, something to maintain temperature regulation, but you don't need this venous reservoir. You don't need suction. In most circumstances, admittedly not all, you don't need an LV vent, and you don't need cardioplegia. And what you then achieve is you take something as busy and complex as this, it fills a room in a cardiac operating room, and you can make it look something like this. It's portable, but it's not just that it's portable or smaller. It's that it has a lot less surface area that's potentially exposed to blood, a lot less splice points. Each splice point contributes to small narrowing, leads to turbulence within the path of the blood as it moves through the machine. That leads to a further upregulation of the hemostatic cascades. That leaves you with the question. The question is your patient, who you ideally want to be hemostatic, and you want to minimize transfusion, especially if it's bridge to transplant population. And you have your circuit. The circuits can get very complex, lots of splice points. This is perhaps an extreme example, but each one of these has areas of disruption of the blood flow, leading to problems with balancing between the proclot and the hemorrhagic side of this equation. And you really want to minimize deposition if you can. If you do a suboptimal job, maybe you get some microaggregates that embolize into the lungs, perhaps, if you're trying to get a bridge to recovery, and you may not detect it. Or, in more extreme examples, you can see deposition. Maybe if you look closely, you can see this faint stranding here, this fibrin deposition on your oxygenator faceplate. These can and do embolize if they're not allowed to dissolute over time. You can get embolic clots. These can be strokes. This is, in fact, a hemorrhagic conversion of an embolic stroke. But you can also get emboli to the mesentery, to the myocardium, coronary vasculature, really anywhere in the body. And obvious reasons, this is very disadvantageous. That leaves us with this. And any of us who manage ECMO patients, we do a lot of this, actually. We stand at the bedside, cross our arms, and we nod our heads as if we know what's going on or what to do next, but we really don't. And so we have to have a framework to approach this, because these are complex situations. This is another slide that probably causes some disadvantageous memories and recall from your days in your basic science courses. And I'm going to skip most of this, but I wanted to focus here on the common pathway. Once you gain entry into the final common pathway, you get creation of active factor 10A. 10A causes or facilitates the cleavage of thrombin to its active form. It requires the presence of other things like factor V, calcium. Phospholipid, of course, is also essential here. But once it happens, a single molecule of thrombin can cleave or activate at least an additional 1,000 molecules of fibrinogen. So then once you get that thrombin, fibrinogen gets rapidly cleaved into insoluble fibrin. It falls out of solution, creating these strands, and these strands become interlaced and interweaved. And as you can see here, this is a colorized version of an electron micrograph. And what you can appreciate is the red blood cells in the glob in the center as a platelet and all this mesh network that's interfacing between it. This all happens really, really quickly. There's a reason we don't hemorrhage to death when we cut ourselves shaving, for example. We are really good at forming clot, and this happens in large part, sure, platelet activation, but also thrombin activation. The thrombin burst. This is a study looking at a half dozen or so porcine models, and the blood is drawn from the body, and it's activated with tissue factor. And notice here, time on the x-axis, on the y-axis is concentration of thrombin. And just notice how rapid this ensues. Within less than 10 minutes, there's a nearly 10,000-fold increase in the concentration of thrombin detected within these blood samples. The propagation and upregulation pathways are profound, and additionally, thrombin acts as an essential mediator within the immune cascade as well. And so by shutting down thrombin, you can address the hemostatic cascade, and in a subtle fashion, you can massage downward the immune cascade as well. So the purpose of anticoagulation then in ECMO is to truncate or shrink the amount of contact phase activation. And if you're unsuccessful, and you will be, at least in part, unsuccessful, to shut down the effects of thrombin once it's formed. And we can do this with pharmacotherapy. Let's pause for a moment. Conceptualize in your head, if you were going to generate or create or design an ideal anticoagulant, you'd have a bunch of competing needs. So let's walk through a few of those needs. You'd want it to be incredibly effective at suppressing the secondary hemostatic cascades, but you'd also want it to be free from other downstream adverse side effects. You'd want it to be free from drug-to-drug interactions, for example. You'd want it to be readily titratable with ideally a linear dose response curve or something that you can predict a response by giving some ill-defined quantity of that parent compound. These patients will require interventions, surgery, procedure suite, chest tubes, et cetera. And so you want to be able to achieve a desired amount of suppression without full abatement if so desired. You'd want it to be reversible. Give an antidote. Completely abate the effect of that compound. And if you can't achieve an antidote, maybe just a half-life that's short enough whereby an antidote is not clinically necessary. We don't have that ideal balanced agent yet, but what we do have is unfractionated heparin. We all know and love unfractionated heparin. It's not imperfect, but it does work. And how it works, the same cascade that I showed you earlier, the way this works is you get this exogenous porcine or bovine-derived product that varies in potency a little bit, and you exogenously extract this, administer it to your patient. It binds to another protein, antithrombin, and once it does so, it forms a complex. That complex is 2,000 to 4,000 times more active at achieving the normal tasks that antithrombin does in the absence of heparin. It acts at two primary sites, factor 10 and factor 2. And it decreases the effect at those two sites. Heparin is imperfect. It has advantages. It has by far, the largest body of evidence to support its efficacy. Lots of studies. It has a lot of assays to titrate it and assess its clinical response. Anti-10A, heparin level, APTT, ACT, even viscoelastic assessment. That's both an advantage and perhaps one could argue even a disadvantage. It's immediate onset of action, and it's reversible with protamine. And protamine isn't perfect either, but it is available should hemorrhage manifest. Its downside effects, it's indirect, which means you have to consider, and maybe even consider replacing that second protein antithrombin in the setting of heparin resistance. It has a long half-life, 30 to 90 minutes, and it can be longer than that if the tissue stores are well loaded, perhaps high doses or post-cardiac surgery. It requires very frequent dose adjustments. Every time you get an APTT or other assay of your choice, most of the times you have to adjust your dose. Safety profile is imperfect. It has a lot of immune effects, including the generation of hyperinduced thrombocytopenia, which leads many providers to wonder what else we could consider. I think direct thrombin inhibitors have risen to the top of that pile, and how this drug works is subtly but importantly different. Here, the exogenous compound, bivalirudin or argatroban, so direct thrombin inhibitors is the class. These are the two most commonly employed agents within that class. These act directly at the site of thrombin to suppress its action. It inactivates thrombin. It doesn't require antithrombin at all to do its task, and it markedly suppresses the action at that single enzymatically active protein. It's dose titratable, rapid onset of action. It has a half-life, at least bivalirudin, is about 25 minutes, argatroban closer to 45 minutes. The majority of bivalirudin's effect is cleared organ-independent proteolysis. About 20% is related to kidney clearance. Essential information I want you all to know about direct thrombin inhibitors. The evidence base is growing, but it remains immature. We are largely or almost exclusively relegated to retrospective data here. But the punchline is a reduction in APTT variation, perhaps a little bit less blood loss and transfusion. It may actually be cost effective despite at least a 20-fold increase in parent drug cost due to less transfusion and less lab assays, and perhaps a little bit reduction in circuit complication rate. Impact on morbidity and mortality. Mortality specifically is worth thinking about. There's a signal of association of benefits, retrospective studies. That signal is maturing, but we don't have any prospective data yet. So I think the verdict is still out whether or not it improves mortality. We talked about its metabolism. The titration is most of the time accomplished with APTT. There's some novel stuff coming downstream, but not yet widely available. Consider this as an alternate or even straight up first-line anticoagulant. Consider it in heparin-induced thrombocytopenia and in the setting of heparin-induced thrombocytopenia. Implementation considerations, just one thing I want you all to know when not to use it. Don't use bivalirudin in settings of stasis, either relative or absolute stasis. And that's because, again, 80% of the parent drug is cleared through organ-independent proteolysis. So regionally, just imagine a myocardial chamber with blood containing bivalirudin, but the flow is poor. The drug effect is going to be regionally lost, and it's going to set up a situation of clot generation. Protocolization is important here, because consider how your circuit is assembled. It has implications for intensity of anticoagulation requirement. Pick a time to start. Consider your agents carefully. And this is sort of that heparin versus DTI conversation. You're going to need a lab assay that you're going to have to choose to how you're going to titrate and steer your intensive anticoagulation. And also that's going to be dependent upon your stability of your dose. If you're widely deviant in your intensity, maybe you want to increase your frequency of monitoring. How about just briefly talking about hemorrhage? What is its incidence? This is using data derived from the ELSO database, and suffice it to say that hemorrhage can and will occur. Cannulation site bleeding occurs in about half of patients. If you think about GI hemorrhage, it's quite common, but how we define it varies by site and center. CNS hemorrhage, I think this probably overstates the incidence. It's somewhere in the 5 to 10% incidence in most published data sets. Hemolysis occurs somewhere in the 20 to 40% range. In extreme settings, it could be as high as 50 to 55%. DIC, of course, depends upon your patient population, but certainly is a relevant consideration. And mediastinal bleeding, it always happens, a question of how severe. As far as management goes, always proceed to the bedside and assess your patient first. How do they look? Are there blood pressures? Are the chest tubes filling up? Do you need to apply an ultrasound to the chest or the abdomen to look for fluid collections? Then look at your circuitry. Do you have deposition and laydown that's progressing? Are you hemorrhaging from cannulation insertion sites? Don't manage without looking at your patient and your circuitry first. From there, get your battery of tests. All of your cell counts, your hemoglobins, your platelet counts, of course, your other more conventional assays, APTT, INR, fibrinogen, all very relevant here. Most of us practitioners are starting to think more strongly about viscoelastic assessment. It provides a nicer holistic assessment. But your battery of tests should be defined upon by the severity of your hemorrhage. And the frequency of your lab testing should also be ascribed to the severity of your hemorrhage. For thrombosis, also this can and does occur. Think about ECMO's Virchow's triad. Placing your patient and your circuit at the center of this triad, of course, there's a lot of derangement and atypical blood flow. You've got turbulence and shear stress. You've got a huge surface area, all of which is foreign despite our best efforts, and you've got areas of regionally low flow. You also have hypercoagulable state. Your patient's inflamed. They're angry. Perhaps it's an ECPR patient who got chest compressions, or maybe they're sepsis or ARDS or they're post-cardiac surgery. But for a variety of reasons, they are hypercoagulable. Additionally, they have abnormal endothelium. They've got disruption of at any point in time you enter a cannula into the patient, surgical disruption, chest tube insertions, et cetera. And all of these predispose to thrombotic deposition. To manage thrombus, it's contingent upon the clot characteristics. So think about where the clot is identified, how large is it, and is it progressing? Then you have to think about organ dysfunction that's secondary from this thrombus deposition. And the intervention is dependent upon where and how large this clot deposition is, the severity of organ dysfunction. It's really dependent upon the characteristics. These are linked variables here, and they should be linked in your own minds as well. Sometimes simple things like anticoagulant adjustment, up titration of intensity, maybe adding an antiplatelet drug. Sometimes it requires circuit intervention. All interventions are worth thinking about, but carry some risk, so that risk-benefit conversation happens every day, all the time. Take-home points here. Think about contact phase activation. This is a great way of conceptualizing why our patients most of the time require systemic anticoagulation. We have a couple of pharmacotherapies that are widely available. Heparin, most centers around the world have access to unfractionated heparin. Direct thrombin inhibitors have a place in clinical medicine. That place, although requires more characterization to see if there's actually a benefit there or not. And be prepared to manage thrombosis and hemorrhage if and when they occur. All right, thanks for your time. Feel free to email me if questions come up.
All right, guys, almost finished. My name is Phil Mason. I'm the recently departed ECMO Medical Director at Brooke Army Medical Center, transitioning to a new job. But right now, I'm going to moderate this last session, question and answer session. Great talks, really high-powered speakers, really complicated stuff, right? You had kind of a whole ECMO course there in an hour and a half or so. So ask away. We have a lot of time. We're going to kind of scoot back the end time here. So if you have questions of any sort for these panelists, please go ahead and fire away, sir.
That was an excellent session. Thank you so much, guys. My question is for Dr. Bartlett. Could you please comment on rest settings, especially FiO2 that we should be delivering in VA ECMO. I have read through Red Book recommendations, but working with some of the other centers in collaboration with projects for ECMO, I do see a lot of variation is whether we are using 21% or higher.
So the question is about rest setting. Can you hear me?
Yes, sir. Go on.
And I thought Kara described this exceptionally well. Just turn it down to 10, 10, 10, and 40% oxygen. That's been the standard for many years. I would refer you to the recent paper by Tatoulis et al. From Rush in Journal of Thoracic Cardiovascular Surgery in April. They simply extubate the patient and take them off the ventilator altogether. I predict that's the way all of VV ECMO will be going in the future.
I was referring to VA ECMO, Dr. Bartlett. What would be your recommendation for
Oh, and VA,
Because
well, VA is different because VA are short runs, so, and you just sent the vent down to any low settings, doesn't really matter, just so you don't overventilate. Oftentimes, those patients have no lung function, so that's when you need VVA to support them. But I usually extubate those patients with VA. There's no reason they need to be intubated, so that's my approach, is just extubate them.
Okay, so room air then. Because the thought, when I discuss this and for centers who are using, say, higher oxygen or 30 to 40% on VA, the thought process is, okay, the coronaries are, very poorly perfused in VA. Maybe they would have this benefit of giving some oxygenation to the lungs, and all the lungs are not perfectly oxygenating. That's why we are on ECMO. I don't know what is your,
That's why I showed that one slide showing what you do with ECMO. VA or VVA, you dial in anything you want. You can make it anything you want, and the heart doesn't have to work, and the lungs don't have to work. So total rest is fine.
It's perfect. Okay. Thank you.
Sir?
Hello again. I represent the international or multi-inter group from Katowice, Poland. And I've got a question about this clotting process you present. Yeah, it's a very big problem with the ECMO. We are fighting with this since 2 years when we met and begin our fight with this process. And we suggest, exceptionally for membrane, we prepare a membrane which is more or less similar like drug delivery system. We have a imprinted material with imprinted anticoagulants. And during the usage of the membrane, we are using all the time the anticoagulants. As you said, bivalvuridine is not always very good, it's true. Heparin is very good, but cannot be overdosed, and you need to very precisely control the amount of the heparin, which is very hard to do with the ECMO included on. So you don't really know the exact amount of the heparin which is in the system.
So I'm going to defer that question to my colleague, but the amount of heparin is unimportant. Don't try to measure the amount of heparin in the blood. It doesn't matter. That's what the 10A assay does. Never use it. It's a waste of time. All you care about is how long does it take the blood to clot.
Yes, directly. And the last information is what we done. We have prepared the material which is drug delivery, the anticoagulant. And the membrane, during the work of the membrane, during the time, is getting more and more porous. So the exchange of the gas is better and better. And the amount of the anticoagulant is on the same level during all the time of use of the system. How do you think it?
Just to make sure I'm understanding the question correctly, it sounds like the question has to do with how do you walk that tightrope balance for the amount of unfractionated heparin that you're administering.
Yeah.
And was part of the question on where in the circuit you actually deliver the anticoagulant?
Yeah.
To kind of take a step backwards, one of the things that we have really struggled with as an ECMO community is a lab assay that actually predicts hemorrhage and thrombosis, which is why we have so many different assays, and most of our experienced centers still rely on a battery of tests. ACT plus oftentimes APTT and or anti-10A. Many centers are migrating in the setting of unfractionated heparin into a viscoelastic assessment to provide a different glimpse at the coagulation cascade. It may or may not be more predictive. But suffice it to say, with unfractionated heparin, frequent lab monitoring is required because you're going to be constantly adjusting the dose. The sensitivity itself changes over time because it's related to that antithrombin effect. Also, unfractionated heparin is bovine or porcine extracts, and individual lots will markedly vary in their potency. And so you are going to have to adjust your dose constantly.
Yeah.
Where you administer it probably isn't all that important. Some centers administer it before the oxygenator. Some will actually administer it within the oxygenator. Personally, I don't think it really matters either way. Direct thrombin inhibitors may offer an advantage, and one of the advantages that I didn't touch on during the presentation is that DTIs actually act not just on circulating thrombin, they act on bound or clot-bound thrombin, which means they have a metabolic activity at the site of formed clot. By doing so, you can suppress further propagation of thrombus, but because of the yin and the yang process of anticoagulation and coagulation cascades, you get gradual dissolution through the fibrinolytic cascade to break down that clot over time. So if you're struggling with refractory deposition, you could consider switching to a DTI, and in some circumstances, you can actually watch this clot dissolute over the course of days.
Yes, thank you for the answer.
So I think the discussion of anticoagulation is fascinating. We could do an entire conference on that, and there's enormous bodies of research on how to better anticoagulate the patients. There's an equally valid movement within the ECMO community to use no anticoagulation, right? DVT prophylaxis only, and I just find it fascinating. It's such an important topic, but yet we can do without it in certain scenarios for certain amounts of time. And of course, the final solution will be an ECMO circuit that behaves like Rain-X on your windshield, and the blood just kind of flows off of it. We're not there yet, but sir?
Thanks. Just a great set of talks, Chris from Stanford University. My question is about, you kind of alluded to, this is for Dr. Steelheimer, is the use of antiplatelet agents. When typically do you use them, and which agents, enteral or parenteral, do you use?
That's an excellent question. About 5 years ago, we developed a guideline to guide antiplatelet therapy at our center. It is built around 3 different agents. The first of which is aspirin. I'm only describing it first because it's the most widely available and we're quite familiar with it. It's also relatively impotent in its ability to suppress platelet activity. The second drug that's on that guideline is dipyramidol. That drug is also relatively impotent, but it is a much shorter duration of action. And so one could imagine if you're thinking perhaps this patient may benefit from that pharmacotherapy, choose a short-acting drug first. Once you've demonstrated stability, then you could switch to a longer-acting agent. Once your center gains more familiarity, you may improve your ability to discriminate which patients may benefit just initially going directly to aspirin. The third drug that is on our guideline is a drug called Cangrelor. For those unfamiliar, this is a P2Y12 inhibitor. It's incredibly potent, it's dose titratable, and the beauty of this drug is that it has a half-life of 3.3 minutes. It's FDA approved in the United States and available in Europe. It is quite cost prohibitive though. And it's a drug that, because of its potency, can be dangerous to apply in ECMO patients. We're not alone in having published our experience using that compound, but I would probably put that in that experimental category for now. When to choose it? Probably patients who you feel are hemostatic, but are continuing to struggle with ongoing deposition on your circuit or within your patient, despite what you feel is adequate anticoagulant intensity. That's when we would choose to use that antiplatelet drugs. We use antiplatelet therapies in 20 to 40% of our patient population at this time, and that percentage is increasing over time, particularly in the era of COVID.
Since there's so much institutional variation on that particular topic, I also want to just pose that question to Kara and Raj as well. The role for antiplatelets in your program, specifically for ECMO, I realize a lot of patients have other indications, but Kara, first, are you using antiplatelet therapy for ECMO purposes?
We have on occasion used low-dose aspirin, maybe, but not with nearly the frequency with they do it. We have used it in patients who've had repeated circuit clots and repeated circuit thrombosis requiring change out and whatnot, sort of on a case-by-case basis.
Yeah, we have not across VV and BA ECMO patients outside and inside of COVID, and we've retrospectively looked at our data, and we have not found increased incidence of thrombosis or circuit exchanges without the use of antiplatelets.
Dr. Bartlett?
One of the problems in ECMO patients, of course, is their platelet count goes down and down and down. They sequester platelets in their spleen and their liver, and the platelets that are left don't work very well. So we looked at this years ago, decided it was always a dumb idea to make the platelet function worse.
So for whatever reason, some of my partners during COVID decided that we needed to start using aspirin for, quote, circuit health. What we saw was a bunch of head bleeds. So we stopped using the aspirin, and you know what? The head bleeds continued, and it turns out COVID is just a mess from start to finish. But we generally don't use antiplatelet therapy, typically for ECMO indications, although, as I said, many of those patients will need it for other purposes. Sir, I think you're next.
Question for Dr. Ramanan and the panelists as a whole. Dr. Ramanan, you mentioned ECPELAMO or ECPELA, and it's a wonderful case study, but I do have a question for the panelists as far as how you guys feel about using balloon pumps and counterpulsation as an adjunct as well for LV venting, in particular, given the issues of hemolysis and placement issues with Impella.
So that's a great question. You know, specifically with the patient that I was discussing, when you don't have pulsatility or you have very little to no native cardiac function, you know, using a counterpulsation device requires pulsation. You know, so if you've got a minimally contractile left ventricle, you know, a balloon pump being a volume displacement device is not really going to be the greatest venting mechanism, right? And looking at Impella specifically, when you've got a transaortic LV vent, you know, the advantage that you have with that is you're constantly washing the aortic root, right, minimizing the incidence of thrombus formation, and you're continuously unloading the left ventricle throughout the cardiac cycle, right, which is in stark contrast to balloon pumps. Another thing with balloon pumps too is the lack of mobility, right? Unless you implant it through an axillary route, most of these patients are not going to be able to walk or ambulate as a result of that, right? But this ECPELA strategy is definitely a plus as far as mobilization and ambulation is concerned.
Okay. We have a few more minutes, ma'am.
Oh, thanks. Ozzy from Stanford Children's. Question for Dr. Agerstrand. So what do you recommend for like whether or not you use an isolator or APRV on your patients? And if you do, when would you activate ECMO? And how do you feel about that? Yeah.
Great question. We actually do not use the oscillator on our patients. You know, on occasion we'll get a call from an outside institution. I think that's coming less and less over the years. So we do not typically see that. We have used sort of a modified APRV on occasion, sort of really like almost like a high CPAP level in some patients in the past. However, you know, less than once a year, I would say. I mean, those would be patients who I think, you know, over time we are maybe 2 or 3 months into the ECMO run, we're thinking, can we slowly start to recruit some of that lung over time? Is that part of the reason that maybe we're still on ECMO and employing that as a strategy at that point? But again, like very, very rarely.
So nothing before ECMO?
No, we do not. We will follow prior to ECMO, and I tell this to all of our attendings, which is ECMO is not an alternative to fentanyl. So we really want to employ all the standard of care, mortality improving therapies. We will insist on, low tidal volume ventilation, a trial of paralysis, and then prone positioning if that patient is stable enough to be prone and the institution does prone prior to ECMO. At our institution, everyone will go through that unless there's a contraindication.
Thanks. And I have one question for Dr. Ramana. With Impella, did you find it to be competing with your ECMO circuit? Because I think we used it once and it seemed like, at what setting do you use your Impella?
That's a great question. So when you're using the Impella specifically in patients with ECMO, we use it as a venting strategy. So it's usually at much lower performance levels, right? So you shouldn't have competition with, retrograde blood flow from your ECMO circuit. So if you usually run it at lower performance levels, P2 to P4, you shouldn't have any flow issues. Because again, it's a microaxial flow pump. It's also afterload sensitive. But, if you're running it at low performance levels, there shouldn't be any issues.
Ma'am, I think you're next.
Hi, great presentation for all the speakers. This is Desiree Machado, University of Miami, Jackson Memorial Hospital. Troy, great slides for anticoagulation. I was wondering if you see, and what role do you see in immunomodulation preventing clot formation? You see a lot of cytokines, platelet aggregation, and I feel that when you have the clot already, you're behind the boat, and hence direct renin inhibitors and heparin preventing the clot formation. But do you see any future strategies for us to use to prevent that?
So I think this is an area that is ripe for more research. The interplay between the immune cascades and the hemostatic cascades has been described for decades, but the potency of that linkage is not all that well described scientifically. We do know that the thrombin itself is a very potent activator of platelets. We know that platelets release a bunch of compounds, paracrines and others that help to upregulate the immune cascades. And so it is straightforward to conceptualize that suppression of thrombin generation or its action, both locally or systemically, should quiet down the degree of inflammation. This may be part of the clinical either equipoise or even superiority of DTIs when as compared to unfractionated heparin, but we can't say that based upon the current level of evidence.
I think they broke inflammation and coagulation apart only so simple people like me could learn them in medical school. They're inextricably linked, but they're so complicated by themselves. It was all I could do to learn them that way, so I think that was probably done as a favor to me only.
Phil, just
Yes,
a
sir, Dr.
quick
Bartlett.
comment on that, because it's important about the difference between cardiopulmonary bypass and ECMO. With ECMO, in its purest form, there's very little inflammatory response, hardly happens. Cardiopulmonary bypass happens all the time, and we're trying to figure out why that is, and the reason is the air interface. Interface between blood and air is a huge stimulus of the inflammatory response as well as the coagulation response. You don't see it with ECMO, that we think that's why the difference exists.
Hello, Jeanne Corriveau from McGill University in Montreal. Great overview and review of VA and VV ECMO. My question actually relates to kind of both. Do you have any insight on management? I don't know how you call them in your centers, but VV RVADs. So an RVAD setup that you would hook up an oxygenator with, especially in regards of fluid management. Because as you know, sometimes your RVAD would ask you to give volume, but your VV portion, we know the lungs don't like volume, so which organ do you sacrifice or which organ do you stress in that case?
Raj, you want to take that? And then Kara, follow
The
up?
cardiologist.
Yeah, so I think volume management, you're talking about oxy-RVADs in particular?
Yeah.
Yeah. So, I mean, volume optimization, it depends on what's driving the pathology, right? Is it predominantly RV failure? Is it predominantly respiratory failure? I think if it's predominantly RV failure, then to salvage the right ventricle is fluid optimization is key, right? So decreasing right atrial pressure as much as you can with continuous unloading with the RVAD is already there. So volume optimization may not have to be as aggressive, right? Since the right ventricle is constantly being unloaded. But I think if it's predominantly for respiratory failure, then, again, it's just a balancing act between, trying to improve pulmonary compliance with diuretics, but only being able to institute it when you have the hemodynamics stabilized, right? If you have unstable hemodynamics, probably not the time to be actively diuresing somebody.
Thank you very much.
You're welcome.
I think it's also important to remember that we're talking with right ventricular hemodynamics, we're talking about intravascular volume. The dry lung is a happy lung adage applies to extravascular lung water. So you're kind of talking about two different fluid compartments. Granted, once again, we were taught how separate they are in medical school. In reality, separating them and managing them separately is quite difficult. Last question, sir.
Hi, thanks. I'm Zach Hernandez. I'm an intensivist at the University of Arizona. Thanks to the panel for the elegant and eloquent talks. I guess my question is primarily for Drs. Bartlett and Agerstrand. I'm not always able to use the circuit to completely take over gas exchange in my patients, and sometimes I need to use the ventilator and the native lungs to contribute. I was wondering how this fits in with the movement towards extubating patients on ECMO. What your thoughts are. Thanks.
Thank you for that question. You're saying the circuit's not enough to support the patient's metabolic needs or oxygenation needs, and how do you do? And the answer to that is if your circuit doesn't do it, then you don't have the right circuit or you don't know how to do it. I get a lot of these calls. I've got this patient, and I want to add another oxygenator, and I want to cool the patient. And I always say, give 3 units of red cells and call me back. I never get a call back.
Yeah.
Thank you.
Hey, so thank you for the lead into my talk for tomorrow about extubating patients and oxygen delivery and all sorts of things like that. Any final comments from the panel? Okay, what time do we start tomorrow, Liz? Actually, I'll turn it back over to you so we can get everybody here on time tomorrow. Thanks.
Yeah, thanks. Thank you, guys.